What's going on, everybody? It's Mark Cargill, your host of the Modern Pain Podcast. And this week, we're going to have Matt Erb, a physical therapist here in Arizona out of Tucson. Matt is an associate director in the Center for Mind-Body Medicine in Washington, D.C. He has a clinical practice with Simon's Physical Therapy in Tucson. He also is really leading the way in physical therapy for mental health. This episode is really chock full of great nuggets that Matt talks about as far as how he interacts with patients, incorporating these type of strategies. It's something I think you'll all get some good value out as far as understanding how to get the narrative piece into your practice, how to understand, how to even communicate to patients to start bringing this type of variable into your practice. Hope you enjoy the episode.
This is the Modern Pain Podcast with Mark Cargill.
Welcome to the podcast, Matt.
Thank you, Mark. It's an honor to be here and speak with you and your audience tonight. Appreciate the work that you're doing in the world to advance our profession.
Well, I appreciate that, and I appreciate you. You've had an impact on myself. I've gotten to know your work through, we co-presented, I think, at the Arizona Physical Therapy Association one year, and I've been able to see your work online and kind of you discussing what you do, really focusing more on the mind-body connection, but obviously a lot more complex than simply that. But I think you go deeper into the biopsychosocial model and somebody I think we can model ourselves after. So I really appreciate you spending some time with us tonight. I'd love to hear a little bit, if you don't mind introducing yourself for the audience, for maybe those who aren't familiar with you. And then we'll talk a little bit about what led you down the path you're on right now.
Yeah, sure. So Matt Erb, I trained my physical therapy at the University of Iowa. I've been out for, I'm dating the fact that I just turned 50 recently, about 24 years. And I worked up in the Midwest for many years. I'm now down here in Arizona, which is, I believe, where you're at in Tucson. But I work remotely for a nonprofit based out of Washington, D.C. called the Center for Mind-Body Medicine, where we do population-wide and community-based stress and trauma relief work. We go into communities after natural disasters, and we're headed to Ukraine next month on the ground, training people in offering evidence-informed trauma support and trauma relief model for people who've experienced trauma. So that's just a little bit of introduction.
We've read some of your work, or I've read some of your work. We're going to link it in the show notes. We spoke about adverse childhood experiences a little bit before we went on, and you've spoke to that. I know as you had your physio practice, really that was a big part of how you would work with some of the folks with some of the complex conditions. I'm sure that walked through your clinic door. I'd love to hear how you kind of what led you down that path to kind of focus on that. I know, kind of the generic physio education. I know at least mine, I got to imagine in Iowa similarly, where it's not as the mind-body connection may not have been there, but maybe you had a professor that influenced you. I'm just curious, what brought you down that path?
Wow, complex question. Right out of the gates early in my career, I was recognizing how limited my training actually was in supporting the lived experience of people, the psychosocial domains, cognitive functioning, the emotional facets. So I took an interest in mind-body on my own. Partly that comes from years of involvement in the yoga and yoga therapy community, which I've trained in. Yoga is, one of my colleagues calls it a psychospiritual technology, is fundamentally mind-body oriented, but also not just the interaction of our individual body-mind, but how that is informed by the environments that we're bathed in. So social environments, work environments, natural, environments, and so on. So I took it upon myself to dive in. I started taking a lot of training in that area, seeking it out. A lot of that interprofessional and transdisciplinary type training where I was taking CE that maybe the average PT wasn't, but it was informing how I wanted to work with people from that whole person lens.
Obviously, you're doing some great things with that, and very impressed with the work. Obviously, going to Ukraine, that's commendable to be helping some folks that definitely probably could use some trauma-informed care over in that direction. Since I spoke to you before the podcast went on, and you had listened to our podcast with Asaf Weizman, I just am curious. I'd love to hear your views, because it's been a discussion we've already had from a lot of our audience members of like, how can we say this is all biology? And obviously, you're taking into account the psychosocial lived experience of the people that you're working with and incorporating it very deeply into your care. I'm just curious where you stand, or maybe some of the challenges you had with that discussion when we try to strip down, saying that maybe biopsychosocial models have kind of pushed us away from the main issue, which is finding these biologic treatments that were going to be the solution to these issues. I respect a soft, and the beautiful thing, we can have nice discussions with people, and it doesn't have to get ugly and name calling and all the things that we see out there in social media. But I'm just curious where your view is on it and what you think about this kind of demarcation of biology and psychosocial versus what we see with humans, where it's obviously very gray, complex, muddy, and not able to be so neatly categorized, I guess.
Yeah, well, first, I really appreciated the discussion, and I appreciate challenges to everything, because it challenges us into looking at our own epistemic humility. And for me, part of that is also cultural humility, which is a topic that we have done a lot of work on in my job at the Center for Mind-Body Medicine. I think for myself, I tend to think of both and non-duality. So I don't see the psychosocial domains of people's lives as distinct from their biological state. And so by addressing them, it's contributing to potentially positive shifts if it's done well and is person-centered and aligned with what people are seeking. It has the potential to create those positive shifts. One example that I would use is Naomi Eisenberger's work at UCSF, demonstrating that social engagement co-regulates inflammation. So the social environment and the quality of that social environment plays a profound role on inflammatory state in the body. So that's just one example. It's the same thing where, when I talk about mind-body medicine, which of course is, some people look at mind-body medicine from the lens of causality, but I tend to look at it as a strength-based way of creating positive influence on the whole of one's physiological state, both at that individual level of mind-body processes, but at the level of doing what we can to support the person's environment. I know some of that is outside of our control as clinicians. We can't change, at least not in the shorter, economic inequality, for example, which would carry a profound influence. And so by taking this both and approach and looking at the idea that all things that we categorize as mind, regardless of your neurophilosophical opinion on the origins of consciousness, right, are represented by biological or physiological patterns and states. That thoughts and feelings are represented in brain body physiology. One of my earliest learnings was from Candace Pert, who used to be on the board of our work, but she discovered the mu receptor. As an aside, had that recognition stolen from her in the patriarchy of the scientific world. But she talked about the work that she did and how the immune system, the inflammatory state, is directly influenced by what's happening at that level of mind in terms of our thought processes, our belief systems, our expectations, our prior conditioning. You mentioned trauma in our paper on ACEs. I look at this every day in terms of the relevance of how the past, what we've lived through, is informing the present. And that's part of why I got into it, is because I had a pretty traumatic, rocky upbringing and a pretty high ACEs score. From the base ACEs test to the expanded ACEs, I had a pretty high number, and that theoretically could predict my death, according to the research. Yet there's also epigenetics that tells us that what we're exposed to, the positive childhood experiences, the things that offset that, can create a counterbalancing effect. And I just yesterday looked at a study that just came out in JAMA on how epigenetic DNA methylation is directly associated to aging processes, and that's predicted by adverse childhood experiences. And so the incentive for writing that paper that you mentioned was, what can we do to offset that? How can we affect the if someone's in a state of prolonged or high threat appraisal from alterations to the development of the HPA neuroendocrine axis or to autonomic functioning early in life, and that's informing how they cope. How do we effectively address that by what we offer in the clinic? So that's sort of the way that I tend to think about it. Not sure if I'm getting off on your question, but I tend to get off a little bit.
No, that's great. I'd love to kind of go further into that discussion, because I think we see these complex conditions, and definitely as you practice more and you might, be senior clinicians in your clinic, where you're going to see some of these complex presentations where we got IBS on board, we have, Ehlers-Danlos, we have POTS, we have all these kind of systemic dysregulatory things. And then as you start getting to know these people, you hear often a very challenging past, and a challenging, and trying to connect those dots for people in a healthcare system that is, not really good at, honoring that story, even bringing it to stage to where it gets, to be told, especially in the biomedical world, you're a biomedical being, and the mind is not part of the body oftentimes, unfortunately. I'm curious what you think we can do as physios to at least get a baseline skill set to do justice to some of that unique, story and the unique lived experience that each of our patients bring to the table. Because I think, we talk about biopsychosocial and how we need to do these things, but I think there's still a gap of, talking about it and then doing it at a level that at least, gives people, like I said, the validation that they deserve when they're, and bringing those factors into a treatment encounter versus, we can talk about that, but then let's just get to the body-based work, where we're going to do the mobilizing, manipulating, and all those type of things. But I'd love to hear your thoughts on that.
Well, there's a lot that informs what I personally feel needs to happen for our profession to better support that. I'll start by saying that we recently, a group of 5 of us, obtained recognition at the APTA in terms of advancing PT and mental health. And that's already recognized by World Confederate, or it's now World Physical Therapy, but in the subgroup of IOPTMH, the International Organization of Physical Therapy and Mental Health. And there's a lot of questions about physical therapist capacity and what is scope and what is smart, safe care in terms of supporting people in the psychosocial aspects of their life. Including if you're working with people with comorbidity. I mean, my practice is clinically oriented, mostly referred by psychiatrists and physicians, a lot of, including integrative health physicians who have an understanding of the mind-body process. And so when you're working with people who are experiencing, have a high ACE history or PTSD, we have to, at a bare minimum, have trauma-informed care and understanding of what supports that. Then we have the whole model of physical therapy right now. I call it assembly line therapy. I'm an outspoken critic of 4 patients per hour and shifting off to rote, exercises on a script by a tech and all this sort of thing. My whole career, I've had an hour per patient. 25 years, I've had an hour per patient my whole career. It's a luxury, according to some people, but it can be a sustainable model. So we need time. And then we need comfort. We need training and mentoring. And we need a model of clinical supervision and mentoring that helps people understand how to support the narrative. Like in narrative medicine, if you take a little extra time to hear what's happening in that person's life, in my opinion, the research supports that is therapeutic. And that it is actually, if I want to use a code, neuromuscular reeducation, because if it's adjusting autonomic central state and tone is shifted, bodily tone, for example, holding or guarding patterns, breath regulation, which influences heart rate variability. So we need to create a better model of supporting people and knowing how to do it safely, how to stay within the scope of our profession. So I hope I'm getting somewhat to what you're asking. Yeah.
No, 100%. I think, and that's a great point you bring up, and I fully support. I remember you talking about this in our state meeting about this is neuromuscular education. The hard science is there, like bringing somebody's narrative and supporting them, and the changes you can see physiologically with that activity is real. And I don't see why we're so skittish to, I don't know how to bill it. I mean, there's hard research and science to show that we are making physiologic, biologic change by having this narrative brought into the room and supporting somebody and having them validated, having them heard, and being able to kind of express some of the challenges that they're going on in their life. We also have research that shows that's what people want. I can't remember, it was at the Holopainen study in Finland, where they looked at what are people expecting from it. I might be confusing names and studies, but what do chronic pain patients want from it? They, I think it was 60% of people wanted to discuss issues they're having in their life. So whether we like it or not, people are wanting to offer these things. And I'm sure we can all relate to sometimes where we're not expecting to hear some of the things that people offer, and they offer, and like, whoa, that's deep. And you also touched upon something I think worth discussing as well, as far as the scope of practice concerns that a lot of PTs have and physios have on, I'm not a psychologist. I don't want to step outside of my scope of practice, but I've talked to this when we spoke with Pierre O'Sullivan and others about how we've created these professional boundaries when we understood pain as a very biomedical process, and where we could just chunk people into these nice little categorical buckets of the physical, the psychological, but we all obviously know science has long, blurred those lines as far as what pain is, what's involved in pain with people. But I'm curious where your thoughts are on where we should be serving patients and while still making sure we're maintaining that professional scope of practice and not infringing. The last thing I'll say too is Peter O'Sullivan said, our psychology colleagues are often more than happy to have us chipping in on that effort. And we can make some great relationships with them, like you've made with some of your mental health colleagues. I'd love to hear your thoughts on it.
Yeah, well, I think I would start by saying that there is really a worldwide shortage of mental health support, and the rate of mental health challenges has skyrocketed, especially since COVID. But in general, I was working on one of the trainings we do today, and someone mentioned that in some regards, and I don't want to misuse the word trauma in any way, but trauma is a spectrum. In modern day life, in some regards, at the bare minimum, carries a very high level of stress that can keep people in heightened vigilance, heightened threat appraisal. And then we have that whole spectrum up to, big classic shock, they call it big T trauma. And so in recognizing that, when I look at a stepped care model, so I recently worked in our work for Ukraine in looking at what's happening out there in the public health system in terms of stepped care for meeting fundamental human needs. I mean, we're all human, and in my opinion, no therapy profession, be it OT or PT or psychotherapy, has a license on human expression or cognition or the fact that we all feel, including in relationship to what's going on in our body. So how do we support that within scope? One, I think we need adequate training. I've taken extensive training and have been working in this field for long enough that, I kind of have that background. But if people ask me for a simple frame, I say we're not diagnosing. It's not really our job to put diagnostic labels on mental health. We're not analyzing. I'm not here to psychoanalyze someone. I'm not giving life advice. I'm not saying, hey, you should leave your spouse. I might provide a forum where the person might arrive at decisions like that on their own through the experience or through the messages of their body or whatever, but it's not telling people what to do. It's not regressive. I'm not intentionally taking people into the past. I sometimes joke a little, but I say, look back, but don't stare. The past has informed the present, but if it's influencing the present, we work with that by coming up with the best possible relationship and response to what's happening right now. And I want to be a guide to support you in getting whatever your needs met are through this whole person model of support. So non-regressive, but that doesn't mean what yoga teacher or massage therapist stuff comes up. When you touch someone's knee, what am I actually touching? I'm touching their life. I may be touching past trauma events. And so if emotions, if trauma memories come up, you need to have a space and not just say, oh gosh, you become uncomfortable and you need psychotherapy, because that's marginalizing, it's shaming. It may be that they need a resource. It may be that they need additional mental health support, But that's through invitation. It's not me telling them you need that. If you'd like additional resources or support, please let me know. I can help you identify the appropriate level of support. So to summarize, non-diagnostic, non-analyzing, non-advising, non-regressive, these are things that are important to me in smart, safe care and trauma-informed care. And it's all provision of choice. The research shows giving people 2, max of 3 choices supports autonomy and choice through choice. So I'm trying to provide things through choice as part of trauma-informed care. I don't know what that brings up for people or for you. I welcome, questions, concerns, and because this is something that our profession needs to define clearly.
Yeah, no, I am 100% with you. I think, we have, as I mentioned already, like a healthcare system that often just glazes over this unique human in front of us and just wants to categorize them into means and standard deviations and things to make clinical decisions. And like I said, very normative based communication styles where the narrative and things just kind of are missing in oftentimes our clinical encounters. For some of the earlier career clinicians who are grappling with this, because it's always a struggle, I'm sure you probably can reflect back to your training days. You've obviously recognized a hole in your practice where there was a subset of patients that you felt woefully unprepared for. I can definitely relate to that. And, my path went down, I was just going to get super complex with manual therapy and realized that was not the complexity I was missing. It was just the complexity of unique humans and the experiences they have and all the things that you've already kind of alluded to today. But for some of the early career clinicians, I'm wondering, what your thoughts are on how to kind of get grounded in an ability to start having these narrative-based communications with patients and to be able to, bring these things into the room safely. You've spoken to it a little bit, but I'd love to hear your advice to some early career clinicians who are kind of trying to figure out, a path forward to start gaining some skill in this.
I think I would start by saying there are simple ways to open the door. So even just asking someone, what has this been like for you? How is this impacting your life? Or if they come in pain, as you're experiencing, these painful sensations in your body, does it bring anything up for you? It's opening the door to affective labeling. Just Lieberman is his name, has published a lot on affective labeling. Just when people say, this experience is making me feel sad. This experience is frustrating me. That labeling is associated with neurocognitive processes, top-down inhibitory path signaling. Prefrontal cortices into limbic and autonomic association regions can be turned on just by giving the people the option to label it. For me, that's not psychotherapy. That is fundamental. What is this like for you? It's part of, for my stance, any good therapy model is giving people those simple openings to express their interior.
Yeah. No, and that interior, oftentimes it's interesting when you open the door for some of those. I am by no means would I consider myself as skilled with you at having those conversations, because that's the one thing I kind of have preached over and over when I teach is that you should look at conversation as an intervention. Like your words are an intervention with somebody, and how you choose them and how you, again, open a door for the patient to express themselves. That is a very skillful thing. What have been the big influences for you? I know you kind of touched upon narrative-based medicine. We've been fortunate to have John Lorner on the podcast, and he's a big proponent and has written a lot about narrative-based medicine. I know you've spoken about your yoga background and different things where, the mind-body connection. I'm just curious, what have been some big, influencers on your ability to gain that skill of conversation? Because obviously just listening to you, and I've listened to you speak elsewhere, and it's impressive to hear kind of some of the ways you navigate some of these challenging situations with patients. But what would you recommend, or what were the things in your past that really, you feel were things that strengthened your skills in this area?
Yeah, I'm happy to answer that. One other thing came to mind just on the last question I want to touch back on, and
Sure.
that's when I invite people into that, it's always body-based. So I really work a lot with sensation, present moment awareness. When people are telling me their story, even if someone, tells me about their recent accident, I say, as you just told me that, did you notice anything happen in your body? I'm trying to frame self-awareness, self-referential processes, and then ultimately tie that back to self-regulation. So when we can teach people how to shift their physiological state. So I do a lot of biofeedback. I'm trained in heart rate variability and EMG down training and up training and, thermal biofeedback, EEG neurofeedback. I've taken all those courses, and I use some of it, but not all of it in the clinic because I try to keep it pretty accessible, practical. But what I found is that when we provide people experiences that shift their overall level of arousal, their physiological state, oftentimes the answers that they need, the feelings that they wish to express, come up all on their own. But I'm keeping it all body-centric, all at that level of embodied. In terms of my influencers, in this area of mind-body processing, I would say that the work that I've done with the Center for Mind-Body Medicine has taught me a lot about what I now, using lofty words, call a phenomenological heuristic. It's enabling people to come to their own answers, their own self-understanding, their own choices, as opposed to me assuming that I know what they need or what they're experiencing. And so it's a sort of it's that non-fixing, where I came out of school and I thought I had to fix everything. Like I should know the answer. I should know how to fix it. There's very little humility in that approach. And so it's taking that stance of, it's not that it's not an anything goes but it's providing that space. And so through my experience with them, I've learned more about the types of open-ended questioning that give people permission to share, to uncover, as opposed to making assumptions. And so all of the different, I've worked with our model is a community-based public health model. It's got evidence published on, children, adolescents, adults with PTSD, and it's got a lot of publications on burnout and healthcare providers. But it's really about that being with people instead of doing to. And we have psychologists, physicians of all kinds, psychiatrists, family medicine. We have nurses. We have social workers. We have clergy. We train teachers. We do social emotional learning in schools. So I've learned from all of them, like being in that type of environment, and it has taught me most of that, and then the yoga therapy community and just self-study on my own.
Sure. There's this belief too of clinicians that, this isn't for everybody. A lot of the patients that come in to open this space, there's this belief, sometimes that, it's a little bit more too spiritual, or it gets way off of the path of what some physios may be comfortable with, or they don't think their patients are going to be comfortable with it. I'm curious with you, is that more of an us issue? I'm sure there's some people who, there might be some challenges, and maybe you can speak to that too, is like, have you had challenges where people are just not able to, or are just putting up the guard and they're just not ready? This is physical therapy. Why are you talking to me about my feelings and all these things? I'd love to hear your thoughts with that. And again, some of the barriers that you think we have as physios, maybe not even just physios, chiros, massage therapists, whoever, of being willing to just, give this opening for people to express and use these open-ended questions. It's this discussion style. I feel like it can fit nicely within a more traditional rehab process because, even traditional injuries, ACLs and things, there's a mind and feelings and experiences and beliefs and all these things behind it that it just helps to have a stage to me, to more comprehensively rehabilitate somebody versus just looking at what their quad ratio is. But I'd love to hear your thoughts on that.
It's a great question. I've spent a lot of time wondering the answer to that question myself. I can say that I have a personal belief, and I'm thinking about Joan Halifax. She is a PhD medical anthropologist, but also a Zen Roshi. And she wrote a paper on an inactive model of compassion. and 6 ingredients that have to prime for the emergence of greater compassion in people. And kind of where I'm going with this is I think that we have to embody the principles of whole person ourselves and how we relate and respond to our health, to be able to take other people into that realm. And this is how we teach people at the center, is we take them through the model and invite people to apply it to their own life, to their own lived experience, in a sense, to kind of do the work themselves. I'm not sure why there is, I would hope that there would be more interest in supporting people at that whole person level. In our profession, it's been a hard nut to crack. Honestly, I'm not sure. In a book that I put together in the chapter on narrative medicine, I listed out. We put together like this pie graph of barriers to engaging in more whole person care and narrative type medicine, and one of that is that self application. There's others. So there's lots of levels of consideration: time, reimbursement, not knowing how to code or document or bill, comfort level, because it wasn't as much in the training. My training, we had a course on psychosocial aspects of patient care, 3-hour course.
Yeah.
What's that going to do? I mean, other than to just touch it, but it's still very reduced. Our profession, in my opinion, is overly reduced in how they're working with people.
Yeah, no, I couldn't agree with you more. I think we still are way too physical of the physical therapy, and especially when we know the physical is so impacted by the mental, the psychology, the lived experience, the society, the things. I think you've touched upon it as well, as far as we have a lot of systemic barriers. I share the same frustrations of how does somebody, express themselves or have any space to express themselves when they're with 4 other people at the same time, and getting, maybe a brief conversation here or there with somebody. Obviously natural history can hang out in a lot of environments and get better. So, that's where I, sometimes think we, as a profession in those settings, entertain natural history as humans do what humans do when they recover. But there are definitely people where that nice, neat recovery process doesn't occur. The reductionist part in our profession, like if you were to have the ability to say, here's what I think our curriculum could be, we're gonna pretend CAPTI barriers aren't there. We're gonna pretend, other, professional barriers. I honestly think there should be a lot of professionals that meld together to create a super professional, like a superhero or something. But I'd be curious what you would like to see in curriculum, and what you think should be just some base things that as physios who are going to navigate, and they're going to see these people in clinicals when they're on clinical. They're going to see these folks definitely throughout their career. It would be nice to have them prepared for it, because I agree with you. We are grossly underprepared to deal with the complexities of the pain experience and some of the narratives that come in our door that we give stage to. Because I remember having people tell me horrible things that have happened to them in the past, and just feeling like shell shocked and like, let's get back to talking about your knee, because I didn't know how to respond to that. Now I feel, through you and others, I feel a lot better as far as being able to give that a space and obviously help it with, connecting them with other professionals as need be. But what are your thoughts on curricular holes that we have in our curriculum, of what you'd like to see in there?
Well, the first thing that comes to mind is that the DPT programs or PT programs are tasked with teaching the test. So the test there has to be a commitment at that level of deciding what it needs to be part of core education in our profession, building it into the test and tasking programs with having to teach it. And for me, that is more of I call it an integral approach to the biopsychosocial model, I'm a fan of the word integral as a derivative of integrative. I know there's a lot of criticism of integrative medicine, but for me, it is a both and. So here at the University of Arizona, which is one of the largest academic centers, research and teaching centers for, the integrative health model, in the country. And I've been immersed in that. Every month I attend a patient conference where the fellow physicians, fellow family medicine physicians present a case situation, and different professionals come in and share their lens on it. That type of model in education can help people start to look outside that reduction to see what are the other facets, what are the other variables. So bringing in some sort of integral whole person framework, that's part of why I put together the book that I did on the foundations of whole person care. What are they? What do we actually want to address that's fundamentally human at least a basic competency? It may be that you're not going to specialize like I do in physiotherapy for mental health, which is where we're getting this recognition here as one of the many countries around the world that's already steeped in that. So I don't know how that's going to come about other than continued advocacy and moving beyond lip service. I remember Dr. Craik, the former editor of PT Journal, said, the time has come to yell about the need for this. And here we are, 10 or 15 years after that was written, and we're not seeing much changing at the level of the DPT program because they are, in fact, tasked with teaching the test and getting people licensed into the field.
Yeah. There are definitely some barriers in that front. And I agree, the licensure exam and I don't know how you would I almost think there needs to be I wish I would have had the opportunity to get, like you said earlier, about some mentoring and having somebody supervise. We just had, Peter O'Sullivan with his Restore back trial, and, CFT, has some definite, whole person, components. And it's a big whole person components because that's often a big chunk of why, the thought is why all the back pain issues, are continuing to, obviously be an issue despite medical advances and all these new ways to intervene. Yet, back pain and chronic pain numbers get worse. I wish I had the solution as well. I just feel like, that mentoring piece is so huge, and it's not an option for a lot of folks. But what would you say? Obviously, not everybody's gonna be able to call Matt Erb and say, "Hey, Matt, would you mind just kind of let me bounce ideas off you on cases and stuff?" But what would you recommend for students who are, trying to find their footing with mentoring? What would be especially in this space? Maybe it doesn't even have to be specific people, but where would you look to have people who can help them start opening these windows of discussions and starting to better handle these difficult discussions that will face them in the clinic? Hopefully they can feel more prepared earlier in their career than I know I felt, but I'd love to see what you think about that.
Well, my network, I have a fairly sizable network of people who are doing mind-body type integrated care models, whole person care models. I'm not sure how the best way to organize that in. I really wish that our profession had a more rigorous standards for clinical supervision and mentoring, especially for people going into specialization areas. But even basic competency, we go through our clinicals and then you're out on your own. And if you get mentoring by chance of landing in a really good clinic with someone, great. But, there's a handful of us out there, I think, who are wanting to see more of this. And we finished that book on whole person care. I tried to spread the word about it, that many of the authors that contributed to that from a variety of professions, sort of expressed, if people are seeking mentoring in the area of whole person care, I'm available. We haven't seen a lot of use of that because I think the uptake is still rather slow. And I think the work you're doing here and some of the other forums that are out there on the online world are setting up models of clinical mentoring. I think, though, that we need to be mindful of how that interacts when it's, conflict of interest and disclosures. Like when I offer mentoring, but I also tell people that it's sliding fee scale, and I've put an emphasis on JEDI with justice, equity, diversity, and inclusion in terms of offering pro bono mentoring and mentoring to the underserved and people who are racialized and minoritized and stuff like that. I think trying to aim for a model that's inclusive for our profession, but that also sort of brings together a network of like-minded people who are really working to advance this. And the last thing I'll say, I know it's a lot, but I'm thinking a lot about David Nichols. I don't know if you've interviewed him, but if you haven't, please bring him on. The death of physiotherapy and physiotherapy otherwise, in terms of looking at a sociological view of our profession and how that can inform what's needed for us to move ahead.
Yeah. David and I have traded emails. I'm a huge fan of David's work as well. I think he has some great points that I think, again, if we need to open our eyes to some of these issues and look beyond just the traditional, I still sometimes see what Instagram and Twitter have to hold about the latest weekend course. And it seems like we're still beating the same dead horse of the next way to intervene and fix things. Granted, there's definitely some better movements, but yeah, I agree. I think Dave is an amazing resource and somebody we could all learn a lot from. So hopefully we'll have him on soon. I want to respect your time tonight, Matt. I really appreciate it. But if there's anything you want to discuss you've already talked about what you're up to. Maybe there's an issue that really is one you feel like we need to chat about tonight. I'm happy to give you the floor of anything you feel like you need to discuss. But also, where can folks, if they want to see your work I'm going to bother Matt to pass on some of the links to some of the studies and some of the folks that he spoke about tonight. I have a copy of his book. Highly recommend it. It's a great book. But floor is yours, sir. Anything else you feel like we need to discuss? And then, like I said, if we can get an idea of how to get a hold of you or see you online.
Yeah. Something that has been on my mind lately, and just in looking at my own health journey, because I myself remember hearing Asaf mention his chronic pain issues. I've had a number of chronic health issues, also have navigated PTSD myself. And as I've worked through the best of the biomedical, the best of integrative and complementary health, and sort of sorted through what works, one of the things that's been on my mind lately is this larger frame of eudaimonia and salutogenesis, which is this sort of helping people cultivate foundational aspects of how they relate and respond to life and living, concepts of impermanence and some of the wisdom traditions. And I've been thinking a lot about that. What does it look like to support people, as they are, where they are in terms of that which is their belief system, their culture, even that which is numinous, this sort of that carries something more on the metaphysical. And what I want to say about it is that, what's his name? Dr. Scott Miller, who founded FIT, Feedback Informed Therapy. I don't know, many people in our profession don't know much about it, but he talked about that he's not really interested in debating the reality of metaphysical phenomena, but it's much more pragmatic, and that what can we better do to engage people in health and healing processes, and what actually informs health and healing. And so where I'm going with this is that there's an old study that was lost. It was in the early 80s by IONS, the Institute of Noetic Science. And they looked at 80 or 90,000 people who had spontaneous remission of chronic illness. And they looked for what were the patterns? What did the people attribute it to? And they were belief systems, facing the crisis instead of avoiding it. Moving from a sense of dependency to a greater sense of autonomy, having strong social relationships, having faith or belief in something larger. So this is the other area that I'm just naming it because this is a whole nother show, Mark, but this idea of how do we support people at this level. Scott Miller did a study that came out last year on the use of psychics, and they compared people's satisfaction with psychics, psychologists, physicians, and family. And guess who performed the best? Psychics.
I was just going to say psychics, I bet. Yeah.
Yeah. So, and again, not debating that reality. It's more pragmatic as what is not getting met in people's healthcare.
Yeah. Fascinating stuff. I'll have to dig into some of that. I know you said the study's been lost, but it is interesting because I think sometimes We have, and you're well aware of the pet peeve I have, as far as like, we are great at having conferences and getting around tables with fellow clinicians, and this is what patients need, and this is what patients need, and rarely are they ever in the discussion of like, well, what do they want? Like, well, why don't we ask them and stuff? And it's interesting when we do some of these studies and we see, man, that is not what we thought. Like, you would think, well, the doctor is going to be the person that they want and respond best to. But it's interesting of that unmet need. And I think we're still not meeting. We're meeting it probably better than we used to. I know, through you and others, I feel like I'm doing better to meet that need. I've really appreciated your work, and I look forward to hearing what you're up to further. I commend you for what you're doing in Ukraine. It's amazing work, and I'm thankful we have folks like yourself doing it. Really appreciate all that you've done for our profession, and can't thank you enough for your time tonight.
Yeah, thank you, Mark. And people can reach out in body or mind, although please know I haven't updated that website in like 5 years, but it's got my contact information if you want to reach out to me. And I'm not sure what you include in the show notes, but I can include links to my published work if people would like to see that.
Yeah, we can put as many links in the show notes as we want. Especially, we had some good discussions on some of the books and some of the research and some of the things you spoke about tonight. So we'll link those on the show notes. We'll link Matt's website. We don't get too picky on web design here. I mean, we're just happy you're online and that people can reach out to you and get a hold of you. So that's out of our critiquing purview here. But again, thank you for your time tonight. For those of you who are listening, don't forget to subscribe to our channel on YouTube. If you're watching this on YouTube, if you're listening to on the podcast channels, it would help us a ton if you'd leave a review, so we can get more of this information out. Folks like Matt need to be heard, and hopefully you can help us do that by spreading the message. So I will leave it there tonight. I really appreciate all your time and you guys giving us all your attention and listening to us this far. We'll talk to you next week.